If you've ever wondered what the difference in the day-to-day is between an ER nurse and a floor nurse, we're going to chat about that. So when you're working in the ER, that's the emergency department. So that's different than the floor. When a patient is on a nursing floor, they've been admitted to the hospital and they're staying. In the emergency department, that's not necessarily true. You can have patients come in and with an issue, get treatment, and then get discharged. So that's called treat 'em and street 'em. They're not actually a full patient in the hospital. They're an ER patient who's getting what they need, and then they're going to leave the hospital. So day-to-day wise, it looks very, very different. In the emergency department, you're doing a lot of what's called focused assessments. If a patient comes in with cardiac issues, chest pain, you as the ER nurse, that is the number one priority. You're not worried about bed sores or a wound on their leg unless it's contributing to the major issue going on, okay? Focused assessment on what the issue is, because in the ER, time is a factor, and it is not like a clinic or their outpatient provider where they come in and say, yeah, I'm feeling short of breath, but I also have this mole I really wanted you to look at. Not a thing. In the ER, focused assessment on what's going on. So their charting looks very different. They're not charting every little thing on every patient. They're charting on the issue that's going on and then going to the next patient, okay? Contrast that to the floor nurse. They do a full head-to-toe assessment. And while there is a main problem, admitting diagnosis, let's go back to that cardiac concern, they're here with chest pain, maybe they're getting a cardiac cath or whatever that is, we're going to pay attention on the floor to skin issues because we want to prevent them from getting worse. And if they have a wound, we're going to talk to the doctor about getting a wound consult and whatever needs to happen for that wound because it's part of their care. There is a little bit of a fine line where, okay, this also isn't something where we're going to do long-term treatment for stable issues. So again, let's say they had that mole that they wanted looked at. On the floor, they're not going to dive into that unless it's really impacting their patient care with this stay. When they get discharged, they'll say, hey, I want you to follow up with a dermatologist to address that, but it's not like an active problem, if that makes sense. So focused assessments in the ER versus head-to-toe assessments on the floor. Another big difference is the amount of patients you're going to see. So in the ER, you have absolutely no idea, no clue. And if you work in a busy urban hospital, emergency department, you are likely going to see patients constantly all day. Now, when I was in nursing school and I did my practicum in a rural hospital, where we had an 8-bed ER, there were shifts where we saw 3 patients all shift. And then there were some where it was constant. There's no predictability at all in that ER environment. And you could be slammed with patients or you could have none or anywhere in between. Contrast that to the floor. When you are working on a floor, the charge nurse knows, okay, we have 20 patients. So that means that we have 4 nurses. And they know that for the shift because there's a certain amount of patients that are going to be there. And they know they need to have that amount of nurses. So you know, okay, I am going to have 5 patients today. And I might discharge 2 or 3, and I might get 2 or 3 back. But there is this semblance of predictability on the floor that's very different than the emergency department, okay? Another difference is how you work with providers. And you know, when I say providers, I mean advanced practice providers, APPs. So that would be a nurse practitioner or a physician assistant, as well as your physicians, okay, your medical team, the people putting in the orders and whatnot. In the emergency department, you're working elbow to elbow with them, literally sitting next to each other all shift. They don't go anywhere. They stay in the emergency room and they're working with you, and they are emergency department physicians. And if you have a patient that comes in with some complex needs, let's say you have a patient that came in with a massive stroke, that emergency department is going to call, or the emergency physician is going to call in the neurologist to come look, and that neurologist is going to come in and see the patient, but that emergency department physician is still that main person, and they're physically there at the bedside. On the floor, it's different. On the floor, physicians round once a day. They're not sitting on the unit next to you talking, hey, what do you think about this? Or did you see this patient yet? Or we've got this going on, have you addressed this? They have, on the floor, they have a list of patients that they need to see that day, and they go around the hospital and they see those patients. They're not physicians assigned to a unit, if that makes sense. So yes, you're working with them, but you really only see them once a shift, and a lot of the conversation is on the phone when you need them. In the emergency department, you're right there with them. So big difference between how you work with providers. Naturally, in the emergency department, with that lack of predictability, you're gonna see a lot more emergencies, okay? You're gonna be dealing a lot more with codes or near codes and stabilizing people and getting that situated. And when you're on the nursing floor, yes, codes happen, but not often. Okay, or if they do happen a little more frequently on a certain floor or at a certain hospital, it's still nothing compared to the emergency department. You never know what's coming in through the door. It could be someone who's in a massive car accident, someone in active cardiac arrest, and it's your job as that emergency department nurse to help stabilize them and get them where they need to go. When you're on the floor, you're more like monitoring and surveilling to see if things get worse, and if you need to put them in an advanced level of care so they're not doing well, then they go to the ICU where the more unstable patients are. So yes, codes happen on the floor, but if patients are that sick where they're coding or getting close to coding regularly, they should not be on that floor. So there's a degree of stability that's you can expect when you're working on the floor in terms of the acuity level of the patient. Finally, another big difference between the ER and the floor is ERs typically have staggered shifts where, okay, you know, we're busier after work or at this time of the day, so we schedule more nurses, and we have, you know, a nurse that starts at 1 o'clock, a nurse that starts at 2 o'clock, 3 that start at 3 o'clock, and you have a staggered schedule. Versus on the floor, nurses all start at the same time. Day shift starts, you know, maybe around 7 a.m. and all the day shift nurses are there at 7 a.m. to get report. And then night shift starts at 7 p.m. so all the night shift nurses are there. So it's a different sort of schedule structure between the emergency department and the floor. So those are some big difference between the two. They're very different units. They do function where they work together, where the ER will have patients come in and they will send patients to the floor. But the care that those two nurses provide is so different that you often will not have hospitals where the floor nurses are floating to the emergency department and vice versa. You really stay in your own department because the workflow is so different. So ER, more unpredictability. You can have higher acuity patients. You can have ICU patients. You can also have patients that are really outpatient ones and you're discharging them. Floor, much more consistent. They require a certain level of care. They're not so sick they need ICU, but they're not well enough where they can just be in the outpatient world. It's kind of that middle ground. I hope you enjoyed that video. Don't forget to like and subscribe. If you would also like some weekly tips right in your inbox, I send out a weekly newsletter with advice, stories from the bedside, my experience, and I send that to you every week. So if you want to get on that email list, it's completely free, and you can hit the link in the description of this video. Thanks, nurses. Stay fresh.